delighted to welcome you on this platform. And I'm sure by presence, you can generate a lot of interest in rheumatology and insight in it. Something which we all need. We are all orthopedic physicians with a knife in the hand to do the surgery. So I welcome the expert, Professor Dr. S.S. Jha, to come to the forum and address all of you. Professor S.S. Jha, please.
Right. Thank you, Dr. Pannak. I'm happy that you are convener of this Rheumatology 2022 webinar, the topic of which is early detection of rheumatic diseases. I'm very happy with the proud presence of our very own President, Dr. Ramesh Kumar Sen. And I must tell you that I have just now talked to IOA Secretary, Dr. Naveen Thakkar. He is on Bangladesh border and he is not able to connect right now, but he has assured me that he will be there by the end of this webinar and he will be blessing this webinar now. So without delaying, I would request our very own President, Dr. Ramesh Kumar Sen, to deliver his inaugural address. Dr. Ramesh, please.
Good afternoon, friends, respected Professor Jha, Dr. Bhushan, and Dr. K.D. Tiwari, faculty members, and all the participants. It's really a pleasure for me also to be here on this webinar on orthopedic rheumatology. This is the first one, as we have seen the series of annual webinars which are to be conducted by Indian Orthopedic Association this year. And as we all know that start the engine exactly needs maximum amount of effort, and once started, all other systems get toned up, get into the rhythm. And that is the work which has been done under the leadership of Professor Jha. This exactly can we see that we have to a lot of thanks to the this team who has started this startup work basically. And the first topic which has been taken is the early detection of rheumatic disease and relevant investigations. It's a very pertinent kind of a subject to start this specialty work in this year. And for this, Dr. Jha has chosen a wonderful faculty, all very experienced and very seasoned teachers. My sincere thanks to all these faculty members for contributing in this webinar. I'm sure the kind of a benefit you will generate to all the participants will go a long way to the benefit of all the people in understanding what orthopedic rheumatology is and how important it's for us in day-to-day our professional experience. Hope all of the participants share all the views and the valuable experience. With that, I thank everybody here and I congratulate and all my best wishes for this webinar. Thank you. Thank you, Professor.
Thank you, President Dr. Ramesh, for your words so that this webinar undergoes. So talking about
Dr. Jha, can I ask Mr. Mahek to mute Dilip Muzumdar,
yes, please.
Mahek, can you mute Dilip Muzumdar, please?
Yes, sir. 1 second.
That is very good. Okay. So friends, let me digress a little from our very own topic, and I take you all to University Hospital of Bern, Switzerland. Now, this hospital has been famous for Nobel laureate Emil Theodor Kocher and Maurice Müller, who founded AO and was aptly named by Sicot as the orthopedic surgeon of the century. Gange took over from Müller and gave the world his safe surgical dislocation and devised surgical strategies to treat pre-arthritic hip. Friends, I would like to repeat pre-arthritic hip and its management by safe surgical dislocation. So his pursuit of understanding these problems established him as the leader of conservative hip surgeries. Friends, I just talked about pre-arthritis only to lead to our further discussion on what we would like to call pre-rheumatic or pre-rheumatoid stage for the evolving stage of the disease before clinical appearance of rheumatoid arthritis do take place. Now, this is the widely accepted term to avoid confusion amongst array of various nomenclatures like very early stage, probable rheumatoid arthritis, very early rheumatoid arthritis, preclinical rheumatoid arthritis, auto-antibody positive arthralgia, early undifferentiated arthritis, progressing to rheumatoid arthritis. So friends, we do accept the terminology pre-rheumatoid arthritis for the evolving disease. Now, why do we want to discuss this topic today? Because the principal goal is early management of rheumatic diseases, which helps in deciphering future likelihood of rheumatic diseases. Therapeutic intervention at this stage is likely to either abort the disease altogether or achieve an early and sustained remission or minimum produce a low disease activity. And this is very important. Friends, the disease-related autoantibodies like anti-citrullinated peptide antibodies and also sometimes rheumatoid factor, they develop much before the clinical features of tissue inflammation have set in. So minimal features developing at the earliest can be labeled as unclassified or non-specific before symptoms and signs fully bloom into rheumatoid arthritis or rheumatic disease. Now for early detection, what are the various parameters that will be required? Patient's history is always very important. I always keep on telling, talk to the patient till the patient gives you the diagnosis. Physical examination is so very important. Lab tests are necessary for early diagnosis and classification too, but they are not the sole factors responsible for making a diagnosis. Radiographic evidence, ultrasound, joint fluid aspiration, and their examination are other factors which could be known. Now, friends, for confirmation of diagnosis, there is a new criteria set by EULAR in 2010, and that still holds good. You can see A, B, C, D, and they have got scores. So this score-based algorithm, if they are added and the addition totals to 6 or more out of 10, that it means that the patient has a definite rheumatoid arthritis. Number A, joint involvement, you can see larger joint involvement, lesser number of points, and if smaller joints involvement, the maximum point allotted is 5. Even if 10 joints and at least one small joint is there, it is 5. Similarly, under heading B, you must have at least one test result for classification, that is rheumatoid factor and ECPA, and you can get 0, 2, or 3. Again, acute phase reactants, CRP and ESR, its result at least one is necessary. Duration of symptoms, less than 6 weeks, more than 6 weeks, and this should total 6 or more for confirmation of the diagnosis. That was rheumatoid arthritis. How about seronegative spondyloarthropathy? We have ASAS criteria for this, and there are 2 sets. Now it says that any patient under the age of 45 years when the disease has started, and if the duration of symptoms are 3 or more number of months. So sacroiliitis on imaging and more than one SPA feature out of the 11, and all the 11 features you can see here. Now, or HLA-B27 positive and 2 or more features out of these 11 are important. Friends, for peripheral arthritis, like in psoriatic arthritis, you should have arthritis, enthesitis, or dactylitis, plus 1 or more of the features like psoriasis, inflammatory bowel disease, preceding infection, HLA-B27, uveitis, and sacroiliitis on MRI or X-ray. So friends, with this much of introduction, I'd now like our convener and a learned faculty himself, Dr. Pannak Bhushan, who is also the head of the department of Shahid Nirmal Mahto Medical College, Dhanbad, to speak on the topic overview of immune response and inflammation. Dr. Pannak Bhushan, please. I will stop sharing.
Right, sir.
Right.
Right, sir. Sir, first of all, it is basic thing. Half of the things have been told by you. The thing is, in a synovial tissue, it is lined by synoviocytes, and it's the synovial inflammation which occurs and starts the rheumatoid arthritis. As told by Professor S.S. Jha, there are pre-rheumatoid symptoms. One is genesis or genetics, second is smoking, and third is couple of bacteria. Besides this, what triggers is not known, but the synoviocytes, that is basically fibrocyte type, they start a chain of reaction. They enter after creating cytokines, because this is the TNF alpha and IL-1 and IL-6 and IL-17, they had been known to generate inflammatory response. These cytokines, then they stimulate macrophages. Macrophages come into the play, then again they release cytokines, and out of the macrophages we get proteases which go and hit the cartilage. Cartilage again produce proteases, so a chain reaction occurs. What actually happens when the T lymphocyte hits, then it goes into the lymphocytes or the lymph glands. In the lymph gland, T and B both are stimulated. And the B, when it is converted to plasma cell, and then it starts producing rheumatoid factor, that is IgM, and the anti-CCPA, that is another antibody. So 75% is IgM, but it is anti-CCPA which is more important. And this cascade of inflammation is, as told by him, is learned much earlier when we look for the antibodies. This cascade of inflammation, we all know, that is inflammation of synovial membrane, production of synovial tissue, stimulation of osteoclast by the rankle or even by the proteases, hitting the bone, eroding the bone, and entering, making a pannus, entering underside the cartilage. So it is all about the inflammation, which is basically not our subject, but we have to know about it. And though I had just taken a class of 1 hour before that, I want to sum up here. In the medical college only I had to take the class. So I want to sum up here because we want to learn more about the clinical things than about anything else. And the bottom line is that anti-CCPA and RF factor are known much earlier than the rheumatoid arthritis clinical manifestations. And once we know that it is increased, we should accept it and go for the treatment along with the rheumatology people. Thank you, sir.
Thank you. Thank you very much. Stop sharing. Please stop sharing.
Right, sir.
Okay. So Pannag has rightly, very briefly, tried to make us all understand that there are two immune systems available in our system. One is innate immune system and the other one is adaptive immune system. Now, friends, the cells which take the lead in innate immune system, and this system, I must tell you, is an inflexible immune system. And look at the cells, all the peripheral blood cells, especially of the white blood cells, like, and other cells also, like monocytes, macrophages. He has talked about macrophages, neutrophil, dendritic cells, natural killer cells, and these dendritic cells are also known as APC, then lymphoid cells, eosinophils, mast cells. They form the first line of defense, and they are necessary to activate and instruct the flexible adaptive immune system, where lymphocytes principally consisting of T cells, B cells, and natural killer T cells take the lead. And friends, it is a story which ends with autoimmunity, that there is a loss of tolerance to self-antigens. And so, how the disease evolves, in summary, we can say that abnormalities in the immune function and immune responses characterizes this stage. Environmental factors interplay with the genetic factors sequentially, and they are suggested to initiate and propagate the required autoimmune process to generate the rheumatic diseases. Finally, inflammatory response of the tissues start producing symptoms. So with this background, friends, we would like to understand what is the spectrum of rheumatic diseases, and it is from no one else but Professor Manish Khanna, who is the President Emeritus of Indian Orthopaedic Rheumatology Association. He heads his institution's orthopedic department and has many laurels to his credit. Without wasting any time, I take the pleasure of inviting Professor Manish Khanna.
Thank you so much, sir. Thanks a lot. Please allow me to share the screen.
Yes, please, just a second. Right. You are there.
So once again, a warm welcome to this first webinar of Indian Orthopaedic Association as well as Orthopaedic Rheumatology. Well, the spectrum of rheumatic disease, I think this is the right time to introduce the spectrum after wonderful autoimmune and immune modulating system explained by two previous speakers. Well, truly speaking, in our clinical practice, orthopedic rheumatology is booming like anything, because definitely traumatology is a part, but 40, 50, 60% of the patient are all around the orthopedic rheumatology, which to some extent things have been gone when it was been diagnosed and given simply by analgesic. We have got specific categories of the diagnosis, the treatment, and the prognosis accordingly.
Manish, are you sharing the screen? Manish, sorry, are you sharing the screen? We are not able to see the screen.
I have already. Let me.
Only you are visible.
Is it?
Yes. Your screen is not there. You are there already. Your slides are not there.
No slides are there.
Is it now?
Yes.
Now coming on.
Yes.
Yeah, now it comes there.
Right.
Please go ahead.
Yeah. So evidence-based management of orthorheumatological disease is the need of the hour. as the evidence-based management for any treatment for the medical science is more important in this era when things are coming up and we are, extending our wings for the most of the troublesome diseases. Now, in this 40, 50, 60% of the cases, the polymonoarthritis or low backache, these are the cases which may be into classical rheumatoid or osteo or a gouty arthritis. But gone are the days when these three were the diagnoses. Now there is a list of the diagnoses. As you move deep down, what we are seeing is the tip of iceberg actually as orthorheumatological patient. Diagnosis, treatment to such various joint disorders sometimes is very challenging because once you are able to diagnose, only then you are able to treat it. So as has been explained, pain, stiffness, deformity, they are the different categories which will be making our wings stronger to move ahead for doing the clinical findings. And as been mentioned previously also, non-specific presentation of warmness, redness, or tenderness is a vague symptom which we try to make it to a particular direction. Past 2 decades, initially the orthopedics was being catered by the terminology of arthritis only. Now, orthorheumatology means various spectrum of musculoskeletal system disorders. It's not around the joint or a periarticular region. It's along the musculoskeletal system. Everything has been involved. Truly, practically speaking, it can be classified according to the nature of the disease. And there are only 4 natures practically. First is autoimmune, for which we are discussing just now. Then autoinflammatory, for which actually anti-inflammatory works. For autoimmune, actually anti-inflammatory is a temporary thing. But for autoinflammatory, actually anti-inflammatory works. Degenerative and metabolic disorder, which is being missed most of the time. Orthorheumatology is not merely a medical rheumatology, but as been mentioned earlier also, orthopedic physicians moving to orthopedic surgery as orthopedic surgeons. So if we are good in basics in our orthopedic rheumatology, definitely we can have a good surgical skill of the subject, like by doing the joint replacement. If you know what is the penis, if you know the things are that we should know that the disease has to be stopped, otherwise the life of the joint replacement is not going to be good extent. So it's a big canopy covering seronegative positive arthritis, specifically seronegative, and the rheumatoid factor is also not there, anti-CCP is also not there, but still the patient is having arthritis, and practically we say the patient is, not having any specific form of arthritis, and the patient deteriorates. Spondyloarthropathy, pediatric rheumatology as JRA, crystal deposition disease, specifically the CPPD, in which, it's not a gouty arthritis or typically a pseudo-gout, simply a hyperuricemia in a patient is again a troublesome situation. Osteoarthritis, for which we know, and infectious arthritis with or without osteomyelitis, yes, in which the conditions where the aches and pains are similar to arthritis. I'm just going to focus on those conditions. Here are the metabolic bone disorders in which osteoporosis and malacia is there. Miscellaneous rheumatic diseases as bursitis, fibromyalgia, soft tissue neoplasm, and tumor-like lesion, which again are entering into the joint and periarticular area. They're again troublesome in initial condition. Of course, when they are full-fledged, everybody can diagnose it. Among various rheumatological conditions, degenerative disorder, we know, are most common in our country and all around the globe, in which the osteoarthritis is most common, in which the knee is most common. Similarly, the spinal degeneration, which is the most common cause for the low backache, is again common, along with the spondyloarthropathy patients, so that we have to scatter them in our OPD so as to move ahead. Similarly, in infectious pathology, still in India, osteoarticular tuberculosis is prevalent, is common. Pot spine is very much common than the Parging infection. And these are again troublesome situation when exact diagnosis, exact point of the time is very important, for which we are going to work up this evening. Among the inflammatory arthritis, most common is RA, practically, we all know. But spondyloarthropathy, and specifically the undifferentiated spondyloarthropathy, we are not able to have any anti-CCP positive, still the patient is having spondyloarthropathy, is again most common. And this is very important slide I have specially kept, that elderly onset rheumatoid arthritis is again a terminology which is to be used, which is being used, it should be used at an old age, when sometimes an old age person can develop a rheumatoid arthritis. Not like that, it is a disease of the youngs only. This year, we are able to come out with a textbook of orthopedic rheumatology. This is the only book in the globe covering all these subjects all together under the one canopy. And we are also having our international journal with us, International Journal of Orthopaedic Rheumatology, which has been indexed at number of places. You can see the list. And by the grace of God, now we are also indexed in the Indian Citation Index, which is being told by NMC to have for all promotion activity, along with the Google Scholar, and we have also entered in the Publon. So this we are moving ahead so that sometime this would be the best journal by grace of God in the world to have the subject to cover. Along with, we are having a lot of RCTs, meta-analysis, case reports published every time, twice a year in this journal. And we are also, for the young orthopedic surgeon, running a fellowship of orthopedic rheumatology, in which last batch was having 20 fellows, and this coming batch is having 15 orthopedic surgeons from pan-India who are especially interested in the orthopedic rheumatology. The reason behind is the backbone for every practitioner of orthopedics is small sprains and ankle and injuries and backache and joint pain, and then the person move ahead for a traumatology and other things. So this is a very good opportunity for the orthopedic surgeons. So blissful medical practice can only be achieved if we are able to contribute to the research, which is the need of the humanity. Subsequent lectures on today would be taking all of us together in making a perfect diagnosis, because evidence-based practice is the backbone, which is the backbone for all of the young orthopedic surgeons, because they are very good in surgical skill as well as the knowledge skill. So we hope that today's all these deliberations would make them more better toward the practice. Thank you so much.
Stop sharing, please.
Thank you.
Stop sharing. Yes.
Yeah.
Okay. So Manish, you have rightly pointed out to one particular disease which goes by the name of elderly onset rheumatoid arthritis. And this particular disease is so disabling and comes up in elderly age and involves peripheral and the spinal column as well. So unless you are aware of it, you cannot make a diagnosis, and the patient, unless treated specifically with biologics and all other DMARD drugs, cannot get the relief. I must congratulate you once again for taking out the textbook, which is the only textbook on orthopedic rheumatology available. You have rightly pointed out that rheumatoid arthritis is one of the systemic connective diseases, and these systemic connective diseases do have multiple other diseases. Most of them we are not talking about today, and we should not also forget that vasculitis and related disorders also need to be talked in our subsequent webinars. Now, may I request Dr. S.S. Amarnath, who is the director and prolific speaker. He is the director of Geriatric Orthopedic Association of India, and he talks on the key topic, early detection of rheumatic diseases. Dr. Amarnath, please. And I stop share.
Thank you, Dr. Jha.
Right.
Okay, hope you guys are able to see my screen.
Yes, yes, it is.
And I'm going to put in the PowerPoint presentation mode. Hopefully that should be full screen now.
No, it is not full screen yet.
No?
No, no.
What happened?
Go for double click. You can proceed even otherwise if you want to. You have to make a double click on this slide.
I did that.
Okay.
I am very surprised with this. Just a second. I'm going to be...
You stop share and again do it.
Yeah.
Yes, you are visible full screen. Now go to your slide.
I'm going to
Share your screen now. Now, this is Dr. Rajiv Kumar's screen.
Oh, I think there's a clash there.
Yes, there must be something wrong. Have you shared your screen now? No, again, Dr. Rajiv Kumar's screen comes.
I think Rajiv, has to probably disconnect.
No.
Rajiv, I think that is interfering with our screen, sir.
Yes, he is. Dr. Rajiv, something wrong. Shall I share my screen first and then see what happens, where things have gone wrong? Yes,
it's very unusual. I mean, we had the screen earlier. We shared everything and it went well.
Yes. Now again I stop share and you go for it. He's on the same wavelength.
Can somebody block him, Rajiv Kumar, please? Mahek?
No. Okay. Now the sound is at least not there. You try once again.
I will do one thing now. I'll go back to the presentation. I'll come to the presentation now here.
Yeah.
Okay. I will start to share the screen.
Please do that. Yes.
That is there?
Yeah. It may not be full screen, you go through.
Now, sir?
Yes. No, not full screen yet, but still I would like that you should go through one by one. You proceed, it is visible.
Yeah, but that will be a little odd, I thought. So I thought, very unusual this time. I mean, we went through that earlier.
Yes.
Just a second.
You proceed as it comes.
Yeah, but now is it there, sir?
It is there, but it is same. You continue. Don't waste your time.
PowerPoint presentation is not coming or not coming?
Your power presentation is coming, but not full screen.
No, I agreed.
You go one by one. Click the next one. This is your header slide.
Yeah. So if I do the next one, is the slide moving there for you?
No, next one is not coming. It is.
So that's what I will. I'll escape that probably.
Yes, it is there now.
No, I think I will do this. I don't know why the share is. I'm going to be double click. This time it came.
The same frame, you can continue one by one.
Now is it coming, sir?
It is IOA 22.
Yeah, is it a full screen now?
No,
not at all.
Not at all. I think we'll forget it. I think I'll go with this now.
Sure.
Sorry about this, folks. Thank you, Dr. Jha, for the introduction. And yes, I'm not going to be talking much on the criterias like what American College of Rheumatology has given, EULAR, European League Against Rheumatology, and APLAR, Asia Pacific League, because it's already been told about. Now, that is where we are reaching to by what we are going to be assessing today. Now, that's an extremely important point. And I'm thankful for the IOA and IOA Rheumatology Committee. And today, with that, we have seen many, many deformities like this. It's saddening to see our own relative or patients, be it in our own backyard or anywhere in the, it's not nice to have this personally or anybody to have this kind. So that is the most important criteria for us. It could be any joint we're talking about. So this is where the whole challenge is for us. So we need to make sure that everything is picked up early so that we can treat early, investigate early, treat early, the right kind of direction, and give them the right kind of, joints that can be definitely hoped for. So today, many of us think, or many of us know, but after having listened to all the faculty today, with all the esteemed faculty's good work that they have done, I'm sure the new and the old, and everyone who is planning to have the orthopedic rheumatology as a practice will definitely understand. If you think you know, I'm sure you don't know what you don't know. So to highlight that what you don't know, today's talk by all of us will give you what you should know, and what you didn't know, you'll know now. Hope you're not confusing there, right? Okay. Keeping that in mind, I'm going to take a couple of seconds on this. That's the reason I said I will be interested on talking about this. So Dr. Panna said, Dr. Manish, and all of them are talking about orthopedic surgeons and orthopedic physician. Now, today we already have a term, orthopedician or an orthopedic surgeon. We are, as rightly said by a convener, we are basically an orthopedician to start with, and we graduate up to the surgical and go beyond that. So that's the reason this basic thing is extremely important for us. Now, like in any other field in our own life, I'm sure all of us accept it, that this is extremely important for us to have early detection, be it financial or health. It is totally important. Why is that important? Because history becomes a very, very niche thing, and clinical examination. Today, thanks to pandemic, in the true sense of term, but no thanks, we are touching our patients virtually. Patients from all over the country. In fact, I've had a few from abroad as well, but majority of the patients from Kashmir to Kanyakumari, India at large, pan-India, patients are reaching out online. It was pandemic which gave law to be legalized for telemedicine in India, and it is just a scratch on the surface. All the more reason, in fact, I was telling the faculty earlier on, including Dr. Jha, the telemedicine, this is what has given me the edge. I think I'm sure all the newcomers and the new orthopedic surgeons are going to be trained, and orthopedicians are going to be trained, or maybe an orthopedic surgeon who retires to be an orthopedician, doesn't matter. There are fellowships happening in India and abroad. I can help you out with that as well. So this is where the key factor comes in. You need to have a good, detailed, comprehensive, where all the history points are picked up. Hence, I'm not going to be focusing on the criteria part and focusing on history point of view and the clinical few points there. And obviously, I'll not be touching upon the investigations because the other colleagues will cover that and already have mentioned it already for you. Why we need this? Because we need to make sure that these joints are functioning normally for us. Unfortunately, I'm not able to show you the video. I'll move on and then take that. See, the biggest challenge is we don't want to get there. We don't want to be here. So let us make sure and take the key points. Now, why we need to do it? Because we need to differentiate between rheumatic and connective tissue disorders. That is the most important thing. And it has to be inflammatory, or it could be mechanical. So there is a little difference in the treatment regime and the kind of protocol that goes through whether being treated medically or surgically. Extremely important. We all know the inflammatory signs like choler, pallor, dolor, rubor kind of thing, warmth, swelling, effusion. I don't need to talk about that, but that's extremely important. Talk to the patients. Dr. Jha was telling, talk to the patient. In fact, the telemedicine guidelines, we all know, we listen. Then we bring out the questions to the patient. And that is where the key factor, what Dr. Jha was mentioning about talk. So get the patient to talk to first. They will give you everything, most of the thing, if not. And then and I know what we need to pick up in our own, questioning so that we can arrive at the right diagnosis even before the investigations are done. So when the prescriptions are generated in an online consultation, we need to give a diagnosis. We can't say joint pain, right? I mean, it doesn't look nice. If somebody sees abroad or anywhere else in the country, they'll say, who is this? When orthopedic surgeon is writing joint pain or a back pain, there should be a specific diagnosis. But mind you, you're making the diagnosis even before the investigations are done. So history taking becomes a big plus point. And clinically, you're not able to touch the patient, but you're still able to do that. But by and large, 98% of the patients are still physical. So hence, it's very important either way. Now, do you have synovitis? Do you have, decrease in the activity of the joint? Now, is there pain? We don't want to give more pain, right? So simple pain in the digits, if you were to blanch the fingernail and what is that? That itself is, imagine, blanching a fingernail is 4 kilo per square centimeter. That's a very lot of pressure we put without realizing. Until we have the pain, we won't know that. So keeping that in mind, we need to make sure some of them, which I was talking about, is STW system, where swelling, tenderness, warmth, loss of movements are assessed. From normal being 0, loss of movement could be, going on to the severe. In the loss of movements also, there are different categories from 1, 0 to 4. If it is normal at 0, 1 would be 25% and 100% would be ankylosis, where there is absolutely no movement at all. So keeping that, we don't want the crepitus to happen, right? They've already reached a certain point. It could be chondromalacia, it could be chondropathy, what we talk about. It could be so many issues that is coming into a secondary arthritis due to rheumatoid or rheumatoid-like. And it could be gouty going on to, secondary problems. So hence, we need to differentiate rheumatoid and osteoarthritis in a massive way. Many times we do come up with a lot of challenges on the rashes that we have. We also have diagnosed with malar rashes to the face. It could be just a photosensitivity. We don't know. Or it could be photophobia. Photophobia doesn't give you rash. Photophobia is for the uveitis in the eyes, but make sure that you are giving that, Next, obviously, we need to make sure if there is any subcutaneous nodules, rheumatoid arthritis, and a lot of other arthritis give you the subcuticular nodules, where osteoarthritis or any other secondary will not give you that. So we need to differentiate that. Now, Dr. Jha was mentioning about vasculitis, extremely important. Now, vasculitis is one of the biggest evolved subject in rheumatology. Today, we have almost like one book of Ramayana for seronegative arthritis and so many things. And I'm sure Manish is going to be updating it as we go on. And I congratulate Manish for bringing the Orthopaedic Rheumatology textbook, the only kind of book available. I encourage everyone to join IOLAR and then probably buy the book as well. And then, you acquaint yourself with that knowledge. Why? Because we need to treat the patient early and make sure that they don't come into that situation. It could be your own relative. It could be your own neighbor. It could be somebody whom you know very well. So obviously that makes a key factor for you. Now, apart from that, we also have a lot of hormonal things coming in. It could be thyroid, or it could be so many, renal related ones, and where there is a huge amount of mixed edema kind of thing coming in. Carpal tunnel syndrome, we see it in a massive way. Many times we pick up that and then we say, okay, surgery. We don't need to do surgery unnecessarily for that. You treat hypothyroidism, or even if they have a mixed anemia kind of a thing, automatically the things get better. Now, where and how, I'm not going to go into each and every test because time is the factor for us here. So naturally, you have a tunnel sign where we tap upon across the line of wrist, where there is nerve coming in, there is pain happening. In the wrist in extension, we do that. In Fallon's test, we do that in a wrist flexion mode. So naturally, it all makes a big difference for us. Very, very important, And taking the next stage, hello?
Yes.
You guys are there. Okay, great, wonderful. I wanted to make sure. Now, in the similar fashion, we have the elbow problems happening. We may have a thumb issue which is happening around the wrist. A lot of patients come with Decker-Reuin syndrome. And then in the shoulder, we ask the patient to touch the opposite shoulder. And then if he or she is not able to do that, what's happening. So we need to understand the rotations. We need to understand the abduction, flexion, all the adduction tests. We assess it, whether it's telemedicine or in the clinical factor, where it could be passive as well as active movements. Both have to be assessed. Makes a very big difference for us. Next. Now, tennis elbow I was talking about. It could be your golfer's elbow on the medial epicondyle. It could be inflamed, or it could be lateral epicondylitis. A lot of people come in. In fact, in the shoulder, a lot of shoulder patients have come in with adhesive capsulitis. And a lot of people have also shown with a huge amount of, labral tear have seen. And it's a different way that we treat now, and definitely that's important for us. It could be bursitis in the olecranon, and we don't jump into conclusion. We need to make sure, is it olecranon bursitis? Check the movement in the elbow. In olecranon bursitis, unlike in arthritis or arthralgia, the joint movements are not restricted. They are full available, and you see the nodule, obviously the swollen bursae or bursa. We need to be very clear on that. And in hip joints, we're going into the major joints now. In the hip joints, obviously the groin, a buttock, or even the Patrick test, we need to understand the flexion, abduction, and external rotation coming to picture, the fiber. A lot of movements we need to check and cross-check. Is it arriving from sacroiliac joints? We need to assess the SI joint as well, not just hip joint. And then when you and I make the patients walk, you talk about Trendelenburg test and a lot of other things with a dip coming in when they're walking. Obviously, we need to check, is there a limb length discrepancy? Thankfully, gone are the days when polio and a lot of other challenges were there. But today, still, people come with limb length discrepancy with a lot of other challenges. You need to make sure. And neuralgia paresthetica, absolutely. When there is a femoral nerve entrapment, a lot of people get confused. This is a key factor. We have learned it. We know what it is. Diagnosing it early and then making sure that giving the right kind of treatment, and that will be better. Similarly, in the same region, you also come up with trochanteric bursitis. There could be some sort of a confusion there in how you treat. I'm not going to come there, but be clear how you can differentiate. That's the biggest thing. And iliotibial band tightness. A lot of patients are doing a lot of work now. Huge amount of work. HIT is the biggest challenge. What is HIT? High impact training is being done by a lot of people on the TV, has been showing up, and then he and she are doing it, so I want to do it. They end up with so many other challenges. Now, obviously, coming down to the knee, warmth, effusion, obviously the swelling, we need to make sure. Patellofemoral compression is the most important thing. And if there's bursitis, is it prepatellar bursitis, or is it arthritis coming into, or is it an infection coming in? All those parameters have to be differentiated. And in the knee joint, we do all the stability tests, be it Lachman or McMurray's or Dreuer sign or anterior Dreuer sign, so many pivot shift, all that we need to understand. Because I'm just highlighting one or two points here, and then you and I need to be extremely clear in examination, not just history. This also makes a very extremely important point for us. Very, very important. Now, coming on to your foot, obviously you need to be very clear. Foot and ankle also is a major part, because God gave us, if you believe in God, 4 limbs, and today we are walking on 2 limbs. And if one limb is affected or if both the limbs are affected, not easy. It's a very, very disabling condition. I was there once. That's besides the point now. Ankle joint is a hinge joint. While doing ankle joint examination, do not forget, remember to examine the calcaneal joints. Extremely important, because when the patient, he or she is walking, when there's a twisting movement, that causes pain. There are issues with arthritis coming in. I'll not touch upon because it's very important. You and I need to pick up that. There are so many problems which comes into tendo Achilles. Today we are talking about so much of advance with uh, science and the technology and the treatment and the stem cell therapies coming into picture. Today, we talk about tendinitis, bursitis around. It could be calcaneal spur or enterophytes giving it enteropathy, and amazing, amazing amount of challenges patients have. Get up in the morning, they have stiffness, they have night cramps, resting pain. All those things have to be kept in mind. Make sure it is also not to miss your tibialis tendon, which could be posterior or it could be anterior. All that is very important for us. Look at the movements of the toes, very important. Dactylitis would be one of the biggest challenges. It could be your NTP joint coming into the point, and it could be hallux rigidus, where there is absolutely no movement, or very painful movement. All those things. And eventually, when you and I ask the patient, whether it's in telemedicine or physically, when you're seeing them, asking them, you see how the patient walks, and you make 80 to 90% of the diagnosis by the way they're walking. It could be coxalgic to simian, where in the simian, most of us may not have seen, the spine surgeon see that. With that, the patient with the back pain, they bend and come. It could be your spondylitis, it could be anchi spine, I don't know. It could be anything in the spine. So you have to make sure that you differentiate just by looking at that, and a lot of diagnosis. I'm going back in time, and during our postgraduate time, I'm sure all our teachers will accept. We used to have patients walk, and we used to supposed to make a spot diagnosis. That's exactly history, clinical examination. You are master in that. Absolutely nothing to get worried about it. You take home messages, minimum. Investigations are there to substantiate what you and I know. But we need to give them a pain-free, full mobilizing joint. Hence, with this, I finish my talk. I thank Dr. Jha, IORA, and IOA for giving me the opportunity to share some thoughts on clinical examination and history taking. Thank you. I'll stop sharing them.
Yes. Thank you, Dr. Amarnath, for a very detailed analysis that history is so very important and subsequent clinical examination has to be done thoroughly. So, well, what is very typical of this nomenclature, pre-rheumatoid arthritis, I would like to emphasize that unfortunately, many a times this becomes a retrospective diagnosis. They are usually labeled before any stage of the disease, but only retrospectively who has subsequently developed RA. So awareness is very important. Now, friends, I would like you all to go through the 5 stages before these at-risk individuals blow out with full clinical picture. So they pass through 5 classical stages. Number 1, interplay of environmental and genetic risk factor. Number 2, production of autoantibodies like ACPA and sometimes even rheumatoid factor. Stage 3, arthralgia or joint stiffness, but no real clinical arthritis. Stage 4, arthritis in 1 or 2 joints, that also early undifferentiated arthritis, intermittent appearing, and is pronounced as phalandrionic rheumatism. Stage 5 is some patients develop into typical established classical rheumatoid arthritis. Friends, the moot question is, why are we discussing about it? One is, the goal is to treat it at the earliest. The other is you can prevent the environmental risk factors. So the preventable environmental risk factors include infection, periodontitis, smoking, as you have already said, dietary factors, obesity, and hormonal factors. And the genetic risk factors we must be conversant with. All of us are aware. HLA-DR4 is the genetic link in about 70% of rheumatoid patients. Associated with DR beta 1 allele, third hypervariable reason, and this is known as susceptibility epitome. There are other two genes which carry twofold risk of developing rheumatoid arthritis, apart from other genes which carry lower risk, and they are PTPN22 and PAD14. Friends, now when we say arthralgia or joint stiffness with positive rheumatoid factor and or presence of ACPA, they can unusually be seen without any evidence of arthritis. After passage of some time only progresses to classical rheumatoid arthritis. Now, asymptomatic patients with positive rheumatoid factor and ACPA are grouped under this heading. The basis is that antibodies related to RA are present in the system prior to diagnosis of rheumatoid, makes it abundantly clear that presence of rheumatoid factor and ACPA are highly specific predictor of the oncoming RA. Now, undifferentiated arthritis, involvement of more than monoarticular affection without fulfilling the criteria for rheumatoid arthritis or any other connective tissue disease. On long-term follow-up of these patients, finally, 30 to 40% progress to classical rheumatoid arthritis. This diagnosis of exclusion does not satisfy the classification criteria of a well-recognized rheumatic disease. It still have the potential for development of persistent inflammatory arthritis. Now, use selectively in future amongst first-degree relative of rheumatoid arthritis patient. So your question must include this: autoantibody positive individuals, twins of RA patients, and sometimes you can go for screening to cover a population with high disease prevalence. Now, friends, if you face a patient with monoarticular arthritis, how do you approach? Professor Abhay Elhans, Professor and Head Orthopedics Department, AIIMS Jodhpur, please. Dr. Abhay. Dr. Abhay, are you there?
Good evening, sir.
Good
Sir, you'll
evening.
have to stop
yes,
screen sharing.
I have done it. You are there.
Good afternoon, sir. And on behalf of, I am very grateful to EULAR and Professor Jha, sir, our President, Dr. Sen, sir, and all the faculty for organizing this particular event, and which is very, very important. And my brief today is to talk about approach to a case of monoarticular arthritis. Am I visible, sir?
Yes, and audible also.
So why study monoarthritis in the first place? When we think about why, the basic question that we need to understand is that a monoarthritis can vary from a standalone medical emergency such as septic arthritis, or it could be a window to an evolving systemic disease. So whenever we have a patient who is presenting to our OPD with a monoarthralgic involvement, we need to be wary of what we are looking at, because it is not just the disease per se, but also what it is holding in the future that is important. Now, before we understand how to approach a particular disease entity or a complex spectrum of diseases, it's important to understand what is the causative influence in the disease process. And when we look at monoarthritis, we could be looking at both inflammatory and non-inflammatory components, and we can be looking at both acute and chronic arthralgic involvement or an arthritic involvement in a monoarthritis. So an acute inflammatory monoarthritis could include diseases such as crystal-induced arthritis, septic arthritis, gonococcal arthritis, acute arthritis of inflammatory disorder, part of an inflammatory disorder, or it could include diseases like tubercular monoarthritis, fungal monoarthritis, which is also becoming extremely important with respect to the COVID spectrum of diseases that we have seen in the past 2.5 years, with a lot of mucormycosis coming into the picture, and certain other infections such as brucellosis and immunoinflammatory arthritis and crystal-induced arthritis. On the other hand, there could also be non-inflammatory component diseases which could present as a monoarthritis, and these could be hemoarthrosis or a trauma, or a single joint osteoarthritis, or neuropathic arthropathy and osteonecrosis. And not to miss out on one of the most important causes of monoarthritis, pigmented villar nodular synovitis. So just to summarize what is the spectrum of incidence spectrum of the disorders that we commonly see, we see a lot of gout, which is about 15 to 30%. We see a lot of septic arthritis in our community and in our country, which is about 10 to 30%. We see a lot of osteoarthritis, which varies from 5 to 20%. We see a lot of rheumatoid arthritis, which varies from 11 to 16%. And there are certain unidentified categories which could present as inflammatory or non-inflammatory monoarthritis, presenting acutely or in a chronic spectrum. So essentially, the approach to how we are going to look at these disorders is that a monoarticular involvement could be septic or what is called pseudoseptic. A septic disorder with a history of less than 6 weeks is an acute presentation, with a history of less than 3 weeks is an acute presentation, 3 to 6 weeks is a subacute presentation, and more than 6 weeks is a chronic presentation. Pseudoseptic disorders could have varying etiologies, some of which we've already touched upon. Now, coming to the history, as Dr. Jha has beautifully elucidated even before, is the window to a possible evolution of a complex spectrum of disease etiology. So talk is not an understatement when it comes to any kind of a monoarthralgic or a monoarthritic involvement, which may be inflammatory or non-inflammatory in origin. So the joint involvement has a particular importance, especially with respect to predilection of the type of arthritis. So different disorders have a propensity to involve certain kinds of joints. Duration of history and duration of involvement is very important. We have to look at constitutional and local symptoms. A history of trauma is very important. And what is the functional limitation it is causing to our patient? Is there a history of morning stiffness and a possibly evolving arthralgia? And are there certain other pointers to disease, such as skin disease or bowel disease, which we need to understand and look at? Examination is important because we have to look at and define the local signs of inflammation. We have to look at and define what is the level of involvement of the joint in terms of range of motion. And we have to look at and understand that is there structural damage occurring to the joint, which can be deformity, either articular or periarticular deformity in different kinds of presentations, which will give us an idea about the extent of involvement of the disease. So the first thing we need to ask is this an inflammatory condition? Are there signs of inflammation? If yes, then the next question we need to ask ourselves is it infective or is it septic? If yes, then whether it is acute, less than 6 weeks, 3 weeks old, or chronic, which is more than 6 weeks old. If yes, then find the pathogen. If it is not infective, then we need to go back to the history, possibly do an aspiration, do a synovial fluid examination, and understand what we're looking at. If that is not enough, we add to the spectrum of this disease diagnostic conundrum by performing certain investigations for peripheral and axial involvement, which is do an ultrasound or do MRIs. MRIs can be gold standard for diagnosis and understanding of the evolution of such disorders. If not inflammatory, then we have to look at the other causes, which are pseudoseptic disorders. So synovial fluid and evaluation. What we need to understand in a synovial fluid is what is the color, what is the clarity of the fluid, what is the viscosity, the extent of WBCs, the percentage of polymorphonuclear cells, and the results of culture. And a standard synovial fluid will have a clear color, a transparent clarity, high viscosity, less than 2000 cells per millimeter cubed, less than 25% of polymorphonuclear cells, and a negative culture. But if you have on aspirate an infective focus, it will have a yellow or a green color. It will be opaque instead of transparent. The viscosity may be variable. There would be a very high content of WBCs in the synovial fluid, and the percentage of polymorphonuclear cells would be as high as 80%. And you would have a culture positive for these different situations. In a non-inflammatory disorder, it's the color which is the give, which may change from clear to yellow. In a hemorrhagic disorder, the clarity and the viscosity may become bloody or variable, and the percentage of polymorphonuclear cells varies from 50 to 75%. On an inflammatory disorder, the clarity and the viscosity again can vary from translucent to opaque, and the synovial fluid will have low viscosity. In addition, the percentage of polymorphonuclear cells can be more than 50%. So coming to individual disorders, when we look at septic arthritis, one of the most important things we need to understand and define and diagnose and label and identify is the bug. And the principle by which we need to understand, evaluate, and treat infective arthritis is that it is an emergency, and that is very important. The treatment and diagnosis depend upon giving the patient pain relief, infection control, and long-term structural damage prevention. When we come to subacute indications such as brucellosis, Whipple's, Q fever, Lyme's disease, tuberculosis, as well as other infections, parasitic and fungal and mycobacterial, there is a Phemister triad which needs to be identified, which consists of osteopenia, multiple marginal erosions, a reduced joint space, which could happen in the subacute disorders, as well as in India, tuberculosis can mimic just about any presentation of any disorder. But the important thing is to identify the pathogen and to treat the etiology accordingly. For example, you have a gout. The important things here are clinical examination, joint aspiration in cases of effusion, doing a synovial fluid examination as and when we can, demonstration of the monohydroxysodium urate crystals in the synovial fluid, performing ultrasound scans and MRI examination to lead to a diagnosis and the kind of involvement of gout. In a pseudo-gouty condition, the important thing is periarticular involvement and a soft tissue swelling, as well as punctate deposits of chondrocalcinosis within the triangular fibrocartilaginous complex. But the most important thing that we need to understand is that an infection can be superimposed in cases of both gout and pseudo-gout. And suddenly, apparently not so severe gouty and a pseudo-gouty arthropathy can present as a very acute and toxic situation. Coming to PVNS, this is a disorder which predominantly affects the hip, the knee, and the ankle joints. The joints manifest as swelling, which becomes painful as the disease progresses. And the most important thing is to identify and the pattern of synovial fluid involvement, the histopathologically, the kind of involvement of the synovium, and the treatment essentially would then lead to a surgical synovectomy, or in today's times, an irradiation synovectomy, where our nuclear medicine colleagues come into the picture. Lipoma arborescens, a slow-growing benign proliferative disorder of the synovium, where the subsynovial connective tissue gets converted by fatty tissue. The pathophysiology, though, is still very unclear, but there have been associations of trauma, diabetes, and steroids. Usually, this disorder affects in the 6 to 7 decades, but can present in a younger age. It usually affects the knee, and the usual presentation is pain, a painless joint swelling, and an effusion. And MRI is the modality of choice for demonstrating the synovial mass containing mainly fat. So that, and synovectomy is a curative treatment, and recurrence is rare. So the basic presentation depends upon understanding the onset and evolution of the disease, the typical involvement of various joints in a particular pathology, identification of the acute, subacute, and the chronic phases, and performance of synovial fluid clinical examination, synovial fluid examination, ultrasonography, and MRI scan as and when necessary in a given situation, and thereby instituting optimal treatment. So when we look at the messages that an approach to a monoarticular involvement or a monoarticular disease spectrum involves, we have to look at a pain and swelling which within a single joint, which requires prompt evaluation because it might be a septic arthritis, a crystal-induced arthritis, or an acute onset inflammatory polyarthritis. We need to understand that acute inflammatory monoarthritis can be an infection unless proved otherwise. The synovial fluid analysis is most important in the evaluation of both acute and chronic monoarthritis. Septic arthritis can destroy a joint, therefore it needs to be properly and timely identified and treated. Septic arthritis can be superimposed on other inflammatory disorders such as gout or pseudogout, and gonococcal arthritis is a pathology seen in younger people. Serum uric acid in cases of gout can often be normal or higher normal, and the diagnosis often requires the demonstration of intracellular monohydroxysodium urate crystals in the joint fluid and visualizing them under polarizing light microscopy. Different systemic disorders such as RA, SLE, IBD associated arthritis, or psoriatic arthritis, Behçet's, and reactive arthritis can all begin as acute inflammatory monoarthritis. Other systemic disorders associated with acute inflammatory monoarthritis can also present in a similar fashion. Tuberculosis, osteonecrosis, osteoarthritis, and neuropathic joint involvement should be considered in the differential of chronic inflammatory monoarthritis. So the take home essentially from me would be, one has to identify in a case of monoarthritis is whether we are looking at a monoarthritis alone, or are we looking at an evolving polyarthritis and a systemic involvement, which is very important. We have to understand that what is a monoarthritis can actually be a medical emergency or an evolving medical emergency, which is infective. The presentation may be acute or chronic, and we need to identify and diagnose the disorder correctly to be able to institute appropriate medical management and, wherever needed, appropriate surgical management. Thank you for your time.
Thank you, Dr. Abhay. You have done very good exposure to monoarticular arthritis, and you have rightly said that it could be part of the beginning polyarthritis. Now, I'm reminded of a very famous saying that, as is known, that pain in the big toe base usually is because of gout. But someone has rightly said that all the first metatarsophalangeal joint pain are not because of gout, but gout can give you pain in the first metatarsophalangeal joint. So you investigate and try to find out if it is not gout, what it could be. So the as you have already said, it could be a polyarticular disease and occasionally presenting with that monoarticular onset. This is the most common acute monoarticular, as you have already enumerated: gout, osteoarthritis, and septic being the most critical diagnosis. You have always to exclude joint infection, and as a rule of thumb, acute monoarticular arthritis, assume infection until proven otherwise and must aspirate. Well, friends, now it is the turn of Dr. Yogesh D. Kamath, consultant specialist hip and knee surgeon, adjunct professor, Manipal University, KMC Hospital, Mangalore, and he speaks on approach for polyarticular arthritis. Dr. Kamath, please. I will stop sharing.
Thank you very much, sir, for that introduction.
Oh, no. Yes.
I'll just share my screen now.
Please.
So greetings from Mangalore, and it's great to be here. I am going to talk about polyarticular arthritis approach, like Dr. Jha said, and Professor Ellens has indeed made my job very simple, because it is many times a part of evolution that a monoarticular arthritis goes and spreads to further joints. So the approach of ruling out infection is indeed the first and the most important pearl we take away from there. Now, when we talk about inflammatory and rheumatoid conditions, misdiagnosis is rampant, and therefore I'm going to talk about many other features which can come along with joint involvement as well. Apart from misdiagnosis, there is a false sense of security sometimes that clinicians get, because this branch is evolving, and it is still not uncommon that one or two blood tests which are done give us a false sense of security, particularly if rheumatoid factor comes negative, because apart from a few basic investigations, many further advanced investigations are not easily available all around peripheral centers. There are, and what I was alluding to earlier was features which can, you can say, predict sinister disease, especially when other organs get involved. So please don't get excited by what you see initially. Have patience, look at the whole picture before you could experience your share of disappointment, both for yourself and your patient. Now, the important thing again here, as Dr. Jha has mentioned and Dr. Abhay clearly showed with different examples, is that these diseases evolve. Therefore, a patient approach, as in the Zen philosophy in Chinese culture, is important here. You have to evaluate and re-evaluate, think and rethink every time, even though you may have instituted treatment. Because if one does not have this approach, one might end up maltreating these conditions. Now, there is often different in cultures, difference of approach, which is why it is important not to be fixed with one line of thinking in these particular cases. Now, the etiology, going back to polyarthritis, can of course be infective as well, and it can be from acute rheumatic fever and streptococcal endocarditis to various different types of gram-negative cocci and viral conditions. there can be inflammatory conditions, of course, like rheumatoid and juvenile inflammatory, apart from SLE and other conditions like seronegative arthritis, particularly psoriasis and reactive arthritis, which need to be thought about. Now, important mention in our country is of tuberculosis, which can present as what we call tubercular rheumatism. Sarcoidosis can definitely mimic tuberculosis as well. Not to forget things which might be thought of as pain syndromes, that is polymyalgia rheumatica and systemic sclerosis, which can have very, very disastrous consequences for the patient eventually. Infective obviously usually presents as acute. The others, inflammatory ones, can be acute or chronic or subacute presentations. So therefore, the importance of evaluation and the Zen approach. I must mention the usually chronic conditions which are non-inflammatory, definitely polyarticular, and the commonest one is OA, which is the commonest again, but can be misunderstood for, overdiagnosed at times when the other things are not looked at. Of course, you've got CPPD, Dr. Ellens has mentioned that in detail. You've got the pain syndromes, hemochromatosis, something not to be ignored, and of course, something which is common but often not alluded to. People who are clumsy or have hypermobility can develop arthritis, and this also can have very, very disabling consequences. Now, clinical evaluation, of course, depends on many factors. We talked about the development of the disease, but also the degree of inflammation, as in helping differentiate infective from the relatively non-inflammatory parts, which do not have, which can have inflammation, but do not have that much of a degree of acute inflammation. The pattern of involvement, like in the morning or certain times of the day, the distribution, as in the central or peripheral joints, certain diseases would have a predominance for either sex, like the ankylosing spondylitis is more in males, but not unknown in females. And of course, some diseases are known at younger and older ages. Now, of particular importance, like I talked about earlier, are the extra-articular features, which signify more sinister disease. And that's what I'm going to take you in detail through in the next few slides. Important, like I said, to evaluate this group of diseases repeatedly. Now, coming to examples, everybody knows this picture of the rheumatoid hand, but look at this. That could very commonly be mistaken for as rheumatoid when one sees a polyarthritis, but the difference here is this is not rheumatoid. You can look. Rheumatoid arthritis would predominantly affect the metacarpophalangeal joints. It might be too early to expect, or in this day and age, when we see a lot of maltreated or partially treated patients, you don't see much of finger deformities like the classical swan neck or buttonholing finger deformities. What you see here is more metacarpophalangeal, ulnar deviation, and the volar subluxation, along with that of the wrist as well. You can see in the other hand, here the metacarpophalangeal joints are spared, but you've got more of interphalangeal and both proximal and distal involvement, which is classical of osteoarthritis, along with the first CMC joint here and Z deformity of the thumb. Now, a malar rash of SLE is well described in all our textbooks, but it is not so easy to identify in skins which are our colors. Therefore, you have to be more observant, look at the eyelids, look at the eyelashes, look right under the eyes where the skin is relatively thinner, and these features could help you make your diagnosis. Now you get different types of rashes. This is the shin with a classical petechial rash. Do not ignore this. It will be evident in darker skinned individuals as well and signifies a sinister aspect, that is vasculitis, which comes along with inflammatory rheumatoid arthritis. Now look at this other rash here. This is scaly and you get more circumscribed lesions. This is the heliotrope rash, which is common and can be pretty much a diagnostic feature of dermatomyositis. Now, psoriasis, as we had talked about in our recent last seminar on spondyloarthritis and various types, we know from there that a good 40% of psoriasis will have arthritis without any obvious skin involvement. And patients often think they've got dandruff in their hair, and you can see the psoriatic lesion right under the hair at the edge. Now, in our country, we would, again, don't go by that, what appears as dandruff. Look under that and separate the hair. You can see the proper scaly lesions of psoriasis. The patient may not have noticed because they wouldn't have looked at their own backs ever. And you can get these well circumscribed lesions very well with arthritis without lesions anywhere else on the body. A diagnostic feature of psoriasis would be nails with this pitting and scaling feature. Again, nail involvement can be present with arthritis without any skin lesions whatsoever. Now, here one more feature. Look out, do a good general examination. That is a case of foot drop, and that with arthritis, you have to think about correlating it together. It can be inflammatory conditions with nerve involvements, which definitely would signify more sinister disease and require treatment. Now, we have seen different organ involvement. We've seen the skin. We've seen various joint involvement. We've talked about them. Don't forget about endocarditis, pericarditis, pleuritis, and lung disease. Very well-known factor. Kidney involvement predominant in SLE and dermatomyositis. Of course, the GI tract in seronegative arthritis and vasculitis and neuritis features. So, coming to the last part, Dr. Jha is going to go on and tell us more about investigations, etc. But it is not just about taking risks and going down to treating. There are many times we remember that what are so-called fancy tests may not be that important. We have to go on very basic tests and then monitor the progression of disease. So a rheumatoid factor, when it is positive, need not be repeated because we know it is there. But a previously negative rheumatoid factor, because of low titers, can, with activation of disease, go on and become positive. So whether to repeat it or no, and when to, is going to be further elucidated by Dr. Jha. But what is more important to monitor is inflammatory markers. Whether the patient is having an inflammatory episode or not will give you a very good idea. And that is more important. That can be done in every peripheral aspect of this country. Important before starting treatment is to actually monitor renal function, and then so on and so forth to specific further investigations. I will not go on too much in detail. I hope I have elucidated simple clinical features and gone on a step ahead from the previous speakers in line with that. Thank you very much.
Thank you. Thank you, Dr. Jogesh, for elucidating the whole topic in detail. And
संजीव जरा मच्छर वाला को जला दो तो मच्छर है
please stop audio from the other portal, which is having some noise disturbance. Well, friends, as you have rightly, Dr. Yogesh has rightly said, and Dr. Amarnath was saying, that when should we label a diagnosis? So many a times we simply prefer to write polyarthritis. What does it mean? Dr. Amarnath has rightly said that definite signs of inflammation, swelling, tenderness, warmth are there, but number of joints will have to be 4 or more. When the number is only 2 to 4, it is known as possy or oligoarticular arthritis. And when there is no arthritis and there is only pain in 4 or more joints, then we say polyarthralgia. That is without demonstrable inflammation with only and there are cases where there is, you cannot say exactly polyarthralgia, it is diffuse aches and pain. You are not able to localize them exactly. So thank you very much, Dr. Yogesh. And now I switch over to my own presentation on investigations and biomarkers in rheumatic disease. I will be happy if the sound coming from what
Dr. Jha, I think Mehak, can you mute Rajiv Kumar, please? Dr. Rajiv Kumar is having a lot of disturbance from us. Rajiv, if you're hearing us, can you please mute yourself? Or Mehak, can you help us out, please? Thank you.
Only mute it, bus. Right. So friends, we must face some realities before talking about investigations, that no rheumatology blood test is 100% positive in any rheumatic disease, nor 100% negative in all normal individuals. So this paradox will always have to be kept in mind. Now, talking about the biomarkers, what are biomarkers? They are biological markers which generally refer to a measurable indicator of some biological state or condition. The beauty of these biomarkers are that they not only help in diagnosis, they can prognosticate and they even have predictive value. Well, friends, the specific diagnostic biomarkers, we are talking about specific ones. We will be talking about non-specific ones also. So the two classical conventional self-established markers are, number one, rheumatoid factor, which you can see here, and the other is anti-CCP, that is antibodies against mutated citrulinated peptides. But in the same category of ACPA, we have anti-MCV, and they are antibodies against mutated citrulinated vimentin. So this also is new. There are so many news arriving. One you can see here, calprotectin, the other is COMP, the third is 1433 eta protein, another is anti-carmylated protein, and then survivin. So friends, let's look at them one by one. Rheumatoid factor, what it is. This also is an autoantibody directed against antigenic determinants on the Fc fragment of immunoglobulin G. Rheumatoid factor is a term to describe a group of autoantibodies. This test is considered the basic screening test and is the hallmark of autoimmune disorder rheumatoid arthritis. It has 3 subclasses, and they are IgM, IgA, and IgG autoantibodies. The simultaneous presence of all these 3 types is usually seen only in rheumatoid arthritis. This becomes very important. In patients with rheumatoid arthritis, IgM rheumatoid factor predominates, and the other subtypes are usually present in lower titers. It is found in the sera of 80% of patients with rheumatoid arthritis. Extra-articular features of rheumatoid are common in patients with high concentrations of rheumatoid factor, but it is a poor guide to the severity of joint disease and to the success or otherwise of therapy. Now, how do we differentiate between rheumatoid arthritis and other rheumatic diseases? As I have already told you, in patients with IgM rheumatoid factor and joint disease, presence of IgG-RF or IgA-RF or both markedly increases the likelihood that the patient has rheumatoid arthritis, and they are not to be found in other rheumatic diseases. So this one thing must be very clear. Now, how it works as a prognostic biomarker? If the value of rheumatoid factor is more than 100 international unit per ml, it is 26 times increased risk. IgA isotype, if it is present, extra articular manifestations will be there. Now we have talked many times about anti-CCP antibodies. It appears long before onset of symptoms and predicts rapid radiological disease progression. Now look at this rheumatoid arthritis diagnostic panel based on only two tests, anti-CCP and rheumatoid factor. If both are negative in one extreme, RA is unlikely. And if both are positive in the other extreme, the likelihood of RA is consistent, predictive, progressive destruction of the joint will take place. So this is very important. Now, again, we have to face this reality that patients with rheumatoid arthritis, anti-CCP can be found only in 67%. Rheumatoid factor almost comparable, 69% of patients, and more than 30% of patients are negative for these two markers. Now, talking about the newer additions, the anti-MCV antibody, this is a second line test, not a first line test. This is a novel diagnostic marker, autoantibodies against mutated and citrulline vimentin, and this is used in which patients? Which are suspected of having rheumatoid arthritis, but RF and anti-CCP both are negative. Their presence is associated with more severe RA disease in comparison to different generation of anti-CCP antibodies. There is increased sensitivity for anti-MCV compared with anti-CCP2. Combined detection of anti-MCV rheumatoid factor provides high specificity for rheumatoid arthritis diagnosis. Friends, this is a very promising biomarker, 14-3-3-eta protein. It can be seen in early stage of the disease. This is a protein which is localized intracellularly, but with inflammatory process on, gets externalized where it can be citrulinated. And the sensitivity is 77%, the specificity is 93%. So combined presence of 14-3-3-eta plus rheumatoid factor plus anti-CCP, the diagnostic rate rises up to 78% compared to rheumatoid factor and anti-CCP alone, which is 72%. So 14-3-3-eta protein is present in early stage of the disease. Now, talking about anti-CAR-P, this is antibodies against carbamylated proteins, and they are found in rheumatoid arthritis patient, but sensitivity is lower at 44%, but specificity is 89%. Compare it with anti-CCP has 54%, rheumatoid factor has 59% of sensitivity. Specificity, anti-CCP is 96 highest, and rheumatoid factor is 91 specificity. COM is a cartilage oligometric matrix protein. This is a specific serological marker which evaluates articular cartilage degradation, as the name includes the word cartilage, and its turnover is detectable both in the blood and the synovial fluid. So this can be detected at both the places. Calcium serum calprotectin is a protein with ability to bind to the calcium, belongs especially inside the leukocytes, also present in monocytes or macrophages. High levels can appear in various inflammatory conditions. The last one, survivin, is in fact a tumoral biomarker, but this is a family of inhibitors of apoptosis, and this has now been reported also in patients with rheumatoid arthritis. Friends, we have talked about the specific biomarkers, the old one and the new ones. Now let's talk about daily performed non-specific markers, and they are ESR, day to day we have it, CRP, serum procalcitonin, serum protein electrophoresis. These two are not very new, but they are also considered in the non-specific markers of inflammation, and that they are called as acute phase reactants. So ESR, it rises in more than 24 hours after inflammation onset and symptoms. Gradually returns to normal, but takes 4 weeks for resolution. It is a measure of Rolex formation, which is dependent on concentration of fibrinogen, immunoglobulin, and some other plasma protein. So aberrations of fibrinogen, immunoglobulin, and other plasma protein can keep the ESR at a higher level. Normal ESR is 0 to 20 in females and 0 to 15 in male. But the thumb of rule formula is that male age divided by 2. So 70 years male, 35 should be the normal ESR. Female, add 10 to the age and then divide by 2. So that should be taken as normal. Now, commonly used techniques are non-automated that we are used to, and automated. The automated ones, they use infrared light, and even in 15 minutes, the results can be given. CRP, friends, we all keep on doing, and as Dr. Amarnath, we were discussing, HR-CRP also is important. So CRP is produced by liver. It elevates within 4 hours of injury in response to IL-6 and other cytokines, and it peaks within 24 to 72 hours, falls rapidly in absence of inflammatory stimuli. Normal value is 5 to 10 milligram per liter, but age, race, obesity, they can affect the values. Now, friends, which one is to be preferred, CRP or ESR? So we have already said ESR is affected by multiple variables, less specific for inflammation. Hypergamma-globulinemia can be responsible for persistent elevation of ESR, prevents it from becoming normal even in subsidence of inflammation, and tends to remain elevated for longer time, decreases by 15% in 1 week after the inflammation subsides. Whereas CRP is not affected by immunoglobulin level because it measures specific reactant, rises more quickly and falls more quickly within hours. So prefer CRP, monitoring early response to therapy when factors influencing ESR specifically are present. When the results for ESR and CRP are discordant, that suggests non-inflammatory factors are influencing ESR. Now, procalcitonin in clinical setting. So this differentiates basically infection from disease flare in autoimmune disease. Disease activity in rheumatoid arthritis and SLE, there could be minor elevations. Potential role of PCT in differentiating septic arthritis from other causes of inflammatory arthritis. Some form of vasculitis also, PCT can be elevated if there is no bacterial infection. Decision of when to start or stop antibiotic therapy can be taken from procalcitonin, and the cutoff level is 0.5 nanogram per ml or more. One thing is very clear, that bacterial infection, there will be values higher than this cutoff, and viral infection, Dr. Amarnath, please get it right, that viral infection, PCT is not elevated. It is not CRP, it is PCT which is not elevated. Another test, serum protein electrophoresis, SPEP. So protein electrophoresis of the serum is done. Change in response to inflammation directly quantifies the acute phase response. Inflammation is followed by characteristic protein alteration reflected on high resolution electrophoresis, separates protein into 5 distinct regions, and they are albumin, alpha 1, alpha 2, beta, and gamma regions. Now, typical positive inflammatory response, what will happen? Alpha 2 zone will increase most prominently, and also other areas. But negative acute phase reactant, there will be diminished albumin peak and diminished beta region. Anti-nuclear antibodies is one test which we commonly keep on prescribing. This is a very good screening test used along with other tests. Look for ANA titer, nuclear stain patterns, and specific subsets. Raise the ANA titer and nuclear stain pattern in SLE 95%. If SLE is unlikely, perform repeated negative test, and in systemic sclerosis it could be present. Specific subsets of ANAs can distinguish various types of autoimmune disease, but from our point of view, juvenile idiopathic arthritis ANA is positive, and there is increased risk of eye disease as well. Well, kidney function and liver function tests are performed, as Dr. Yogesh has also said, that they should be examined and assessed even before starting the treatment. Liver function, tests for liver function may give abnormal results already in patients with rheumatoid arthritis. Serum concentration of transaminase and alkaline phosphatase may be moderately elevated when the disease is active. Thyroid function, surprisingly, we orthopedic surgeons are not very much aware, but it has been found that mean T4 level in rheumatoid arthritis patients were significantly higher. T3, 2 standard deviation above control. T4 levels were also higher. TSH levels were more than 2 standard deviations. So thyroid hormonal defects are related with the disease duration and not with the disease activity. Well, CPK, creatinine kinase, this is a muscle enzyme. So patient with rheumatoid arthritis usually have low CK values. Even mild rise in CK levels may suggest presence of polymyositis, which may be confirmed on muscle biopsy. High incidence of vasculitis in biopsied muscle suggests that it may be primary event in the pathogenesis of myositis in rheumatoid arthritis. Complete blood count is one very general test and must be prescribed because this determines the number of WBC, RBC, and platelet present. Some rheumatic conditions or drugs used to treat arthritis are associated with low WBC, leukopenia, low RBC, anemia, and this is very important. If you find a low platelet count, thrombocytopenia, you think of it, and even without treatment, or even if the patient has been treated, that it might be one of the rheumatic diseases. Now, genetics, we have already talked about. HLA-DR4, human leukocyte antigen, is genetically anomaly found in white blood cells, risk of developing arthritis. Genetic factors gives prevalence of 2 to 12% in first degree relative of rheumatoid arthritis sufferers. That is approximately 10 times that of other population. The human leukocyte antigen component accounts for around 30% of the genetic risk. Now, this synovial fluid finding has been discussed in detail by Dr. Abhay Elhens, and he has rightly said that the polymorphs in inflammatory condition is almost double, and the cell count is more than 2,000 and maybe as extreme as 75,000. Now, bone marrow examination sometimes is also a mounting evidence that osteoclasts are involved in the pathogenesis of a component of the focal bone erosions in rheumatoid arthritis, and sparingly this can also be performed. Friends, talking about radiological assessment of progression of the disease, there is a method known as modified sharp 18 method. We have 44 joint scores of MCP, PIP, MTP, first IP joint of toe, first CM joint, and carpal joints. If there is increase in the score of over 5 joints in a year, this tells us that there is a bad prognosis. Well, use of biomarkers for prediction of response to biologic therapy, is it possible? Yes, we can predict that if this particular biomarker is present, it should be preferably treated with this particular biologic. Like, for example, if rheumatoid factor and anti-CCP both are present, they have a predictive role with rituximab. But if both are absent, anti-TNF should be prescribed. Anti-MCV, if it is not present, anti-TNF again. Anti-MCV present, rituximab. 1433 eta absent or low levels, then tocilizumab and anti-TNF. Comp, if it is present, absent or low levels, adalimumab is the drug of choice. Calprotectin, if it is present, adalimumab, infliximab is the choice. Survivin, if it is absent or low levels, infliximab. So if this predictability of the different biologic therapy can be ascertained, it will be very good. So friends, I would like to conclude that diagnosis of rheumatoid arthritis in early stages, we should try to find out if other factors are not present, determination of anti-MCV along with rheumatoid factor and anti-CCP. This is a useful diagnostic and prognostic tool. Now, what future has in store if we can identify a biomarker for pre-treatment detection of responder versus non-responder? This is an unsolved issue, but there could be a likely solution if 1433 eta protein can be extensively studied. Thank you very much. Now, the topic is open for discussion, and as well as I will request our president of IORA, Dr. Dilip Mazumdar, for making a brief or summary of whatever has transpired regarding early detection of rheumatic diseases. Dr. Mazumdar, please.
So you stop sharing, sir.
Yes, I.
Hello, Amarnath ji. Hello, nice.
Hey, namaste.
Yeah, namaste, namaste. So,
Namaskar.
what shall I tell about all these things? Because galaxy of golden speakers.
Before that, please. Our secretary IOA, Dr. Naveen Thakkar, is visible. Dr. Naveen.
Yes, sir. I could join now.
Welcome, Naveen. Welcome.
Better late than never.
Good evening to everybody. It was
Good
a
evening,
fantastic
good
day.
evening, Naveen. Good evening.
Sorry, sir. I was on the holiday, and just now I am on the way to the Shillong. So
Very good.
Shillong, acha. Shillong is far away from.
Northeast. Yes, sir. Yes, sir.
You have kept your promise.
I'm on the car.
Yes, and you are visible.
Yes, sir.
And audible
I
as
could
well.
connect. I could connect now. I got a network now.
Right, please.
Yeah.
Go ahead with your emotions.
Yeah.
Yeah. No, sir, very much thankful to you for conducting such a very good webinar from the IO side.
Convey my
Very much-
affection to Agrawal. Dr.
And
Agrawal.
I'm thankful that Dr. Ramesh Sen sir has joined here, and he has started the process very well, sir.
Yes, yes, he did that. You have
Sir, you can go ahead, sir. Dr. Majmudar, sir, you can go ahead, sir, with your
Okay.
summary.
No problem.
Thank you very much.
Becker, thank you very much.
Right.
Yeah, enjoy there.
Okay, so Dr.
So
Majumdar.
actually, Jha Sahab,
Yes.
Shiv Shankar Jha, you are the teachers of all the teachers, and you have got a band of golden speakers today.
Yes.
And among the golden speakers, you see, I don't know whether Professor Bhushan is there or not.
He must
Bhushan
be
has
there.
left, I think.
Okay, maybe.
But still then,
okay.
Manish has also left.
No, Manish is
Amarnath
there. No, Manish is there.
Sir, I'm here. Sir, I'm here. I'm here.
Manish is there, I think. Manish, very nice to see you. So, see, Bhushan, I think Professor Bhushan is busy. He has left. So,
okay, Dr. Majumdar.
Yeah.
I must confess that when I decided the various topics, I allotted to Professor Manish that what is the spectrum of rheumatic diseases for our general orthopedic surgeons to understand. And he very nicely incorporated all that comes within that spectrum. I was very happy he talked about osteoarthritis as well in the net of orthopedic rheumatology. And he coined two words, autoimmune and auto-inflammatory. So, Dr. Manish, would you again like to expand a little between these two, that how do you differentiate between autoimmune and auto-inflammatory diseases? Yes.
There is some sound problem. I'll join it later on, just to correct it. So
okay.
I'll clarify it. Just a second, sir.
Okay. So, in the meantime.
But I actually, Professor Jha.
Yes.
I want to get one or two things clarified.
Please.
One is from Amarnath and another is from Abhay. So Amarnath is a very good reputed practitioner. You know, he has got a very good knowledge of this rheumatoid, and in olden days the journey to Amarnath was very much tedious also, and people could not reach Amarnath and visit and all that. But nowadays you see there is a very shortcut road and shortcut way of, as you have told, that anti-CCP or rheumatoid factor. This both will cover up 70%. 30% is actually dubious role. We do not. But in between that, there are other autoimmune diseases that we like to clarify from Manish, that how they influence, they enter into and destroy the joint later on. There are spectrum of rheumatoid diseases that affect the synovial tissue or collagen tissue, and ultimately they reach the joint cartilage and they damage it. So how does these things happening? And even with the new form of treatment, or as you have told about the small molecules and all that, still it is happening. So why? How it is happening? Is there any change in the autoimmune system mechanism?
Dr. Manish is not there. You wanted to know something from Dr. Amarnath?
Yeah, can Amarnath say about these things, that how the changes occur in the immunochemistry level and the pathway changes? Not in all cases, but some of the inflammatory cases, this has been found out. So how this is happening? Is there any way to check it, or divert it, or delay it, something like that?
Yeah, that is a multi-million-dollar question, Dilip. So why that is happening? I know that is a big why, big why. Now, the 30% who are negative for anti-CCP or even RA, we categorize them into seronegative arthropathy. Now, in seronegative, the book is as big as probably one volume of Ramayana or Mahabharata, the seronegative arthropathy. Right. The allied possibilities have been given, and yes, there are a lot of issues, and Dr. Jha has already given us the new biomarkers coming in, and then the old ones which are already there, with the specific and the non-specific ones which you brought out. So naturally, those things are there. Manish is back.
Yeah. So, sir, actually, autoimmune and autoinflammatory are a little bit of sister concerns. Basically, autoinflammatory diseases have a hyperactivation of innate immune system, which is causing it actually. Although, and we know in autoimmune diseases, autoinflammatory diseases has a hyperactivation of innate immune system. Although with the abnormalities of adaptive immune system, it is an autoimmune disease. So it is a sister concern, basically. Like many of the celiac diseases, many of the diseases are there which are autoinflammatory, and there are some autoimmune. So they are all sister concern between the innate immune system and adaptive immune system, to differentiate into two.
Right. Thank you. Yes. Anything else? Now, can you sum up, Dr. Mazumdar?
Yeah. So everyone, the speakers that you have actually requested to speak were the excellent speaker, golden speaker. Everyone has produced an ornament, and that ornament will be useful in the early diagnosis. Say for Bhushan himself is an ornament. Immune response and inflammatory behavior of this musculoskeletal system he has highlighted. Manish has the highest evolution. Manish is nothing. What is Manish? Manish is the highest evolution of man. He is the actually peak of all. He is the apex of spectrum of the rheumatoid that he has told about in his book. That is a new book has come and revolutionized the first time in orthopedics, because rheumatology books were available. But in orthopedic rheumatology, there are no books till today. Only paper and this journals and all these things are available. So Manish has told in that book, he has actually kept many things, many secrets for our. And Amarnath is a good practitioner, reputed practitioner. Early detection of rheumatology, and as he told you that in olden days it was very difficult. But now, because of this obvious and this lines of investigations that he has told, including the bone marrow, he has told all these things. So that actually helps us in the diagnosis. And secondly, the Professor Abhay. Professor Abhay has given a very good grace and knowledge of the approach to the differential diagnosis. Even he has talked about the septic arthritis. He has talked about the septic arthritis, how the septic arthritis actually pose difficulty in our diagnosis. And he has told about the bugs, which actually influence our diagnosis. So monoarticular rheumatoid, actually Abhay's talk was on monoarticular rheumatoid and diagnosis, early diagnosis. Yogesh has again bestowed in other way that he has actually, I could not understand what the Jain philosophy.
No, he said
Jain philosophy I could not understand, but polyarticular he has very well, very nicely have articulated and shown that you may be deluded with something, you may be deluded, you may be cheated. The rheumatoid factor is negative. So you do it again, you do repeat the rheumatoid factor. So you may be deluded in the beginning. So beginning has to be checked in the beginning. Otherwise there will be disaster. So your Shiv Shankar, the top of wisdom and effects of all, has shown us the positive help from the biomarkers in the issue of the rheumatoid early diagnosis. So thank you all of the speakers again, and wish you again to see you in the next time, so that another highlight we can get and another enrichment we will get in the rheumatoid arthritis. Till we get this the rheumatoid IRA con in Calcutta, soon we'll be planning in the month of May, early May. So
Right.
we'll
Now
tell you the date. We'll tell you the date, and we'll invite all of our speakers, and including our Bhushan. Bhushan is the ornament. I told you in the beginning that he is the ornament who has actually talked about the capping the immune response and the inflammation.
Thank you. Thank you.
Very much.
Thank you.
Thank you. Thank you. Thank you.
And before really concluding, I'd request our Dr. Tiwari, KD Tiwari, who was chairman in 2021 and has become a respectable member of this committee once again, to propose.
Thank you, Jha, for giving an introduction. And it's my pleasure to be here again, once joining the rheumatology faculty of the rheumatologist. And it's my sincere thanks to our president, Dr. Ramesh Sen. He started the ball setting rolling and started very well taken over by the Manish and the Dr. Amarnath and Abhay Alliance and Dr. Kamath. And of course, you were always there to catch up the thing and sum up and highlight the thing. My special thanks to Dr. Panag Bhushan for bearing and carrying the flag of our Central Zone. And though he was busy somewhere in the OT, but he joined and started the thing slowly. And my again sincere thanks to our own Dr. Majumdar, IOA president,
Thank you.
who has been here for summing up all the things. And I am not forgetting ARTHRITIS faculty, Mr. Mahat,
Yes.
for coordinating and conducting the things very well. So, once again, thanks to everybody. Say goodbye to the galaxy of rheumatology. We'll meet again.
Thanks to our president and secretary IOA as well.
Thank you, sir. Thank you.
Dr. Yeah, he was on the way toward the Shillong, but he joined. That's great.
Yeah.
And I have a request, sir, just to put to everyone, that as with the passing time, orthopedic rheumatology is most important thing, which starts with the orthopedic practice in the clinical time when all these young orthopedic surgeons comes out. And we have a wonderful response from young orthopedic surgeons who are learning and sharing the things. So I'll have an appeal to all the respected faculty member to be a part of the orthopedic rheumatology group, so that at least we can convey what is rest going on. To be a member of IRA is also very important for all of you to be with us always in our board with discussion which is going on in the group. Thank you so much.
No. It was a very well planned webinar, and this is the only committee which plans and does the rehearsal completely. And Dr. S.
You're right.
Great homework and continuous support. So we are very much thankful for such a wonderful faculty.
Thank you very much. Any
Thank you.
concluding
Thank you,
remarks
everybody.
from the president? Any concluding remarks?
Yeah. So
Thank you, Professor Jha.
No, just a minute.
nicely
Just a
organizing
minute. President Dr. Ramesh. Yes.
thank you.
Ramesh Sen is here. Yeah, Ramesh Sen ji, namaste.
Namaste. So definitely, at least because it has been the first webinar also, and the enthusiasm with which Dr. Jha has done the work of this starting it out, and definitely this has played a big role in getting our activities in the rheumatology forum also. I hope with this kind of a beginning, we'll continue working on this subject also, and probably it will be able to get benefit to all our viewers, all the participants also, to get the best of it. And thanks a lot again to all the faculty to have contributed so well in the preparation. Thanks a lot.
Yeah,
and
sir.
best wishes.
Yeah, sir, I started getting messages. So it has gone to many viewers. So it is spreaded very well. And there is a good response from the viewers. Yeah, sir.
Yeah. Thank you. That encourages us.
Thank you very much.
Thank you so much.
As concluding remark, now I declare this webinar closed. And
Yes, sir.
I especially thank Professor Jha and Dr. Ramesh Sen for everything. With a
And
bird's eye
our-
view of Dr. Thakkar.
Yeah.
Thank you, sir.
Right, sir.
And hopefully next month we will be having another one. Right.
Thank
Sure,
you.
sure.
We will be having, sir.
Right.
Thank you.
Thank you. Bye-bye.
All the best. All the
Thank you.
best.
Bye,
Thank you. Bye bye, sir.
डॉक्टर
Bye.
तिवारी आप बाहर यूएसए से
Yeah, I
आए
returned back to India.
ओके यस
I was in USA for last 2.5
Right.
months.
राइट सो यू हैड अ
Now
गुड
returned back.
राइट थैंक यू वेरी मच बाय गुड
Thank you.
नाइट
Bye-bye.
Bye.
रात्री मंगळवार